Hey class, it's Dr. Wettendorf here. Thought I'd do a lecture kind of going over LFTs that I think you might find helpful on a, I don't know, certain project you're working on this week that is due this weekend, a CDM of some sort that involves LFTs, also involves some anemia stuff, but a lot of focus on LFTs. Had a student with me yesterday doing clinicals who we encountered 3 patients that had abnormal LFTs, and this student got to see the workup of a patient with abnormal LFTs, which I thought was of great benefit to them, but I also think would greatly benefit the rest of you guys right now, especially as you're working through this CDM. So hopefully this helps. Late last night, scratched out a few drawings. Hopefully it makes this clearer. Literally scratched out. So if it looks like that a 3rd grader did this, that would actually probably be an insult to 3rd graders, because my handwriting is in my drawing is that bad. I can do many things well. Drawing is not one of them, as you're about to find out. But hopefully with me walking you through it, this kind of makes some sense. So let's go ahead and dive into this here a little bit, and hopefully you're able to figure some of this stuff out. Also, yes, it is 5:15 in the morning. Is that right? I'm sorry, 5:35. I had breakfast, so that took 15 minutes. Anyway, 5:30 in the morning. I'm not nearly caffeinated enough yet, so if I ramble a little bit, I apologize. Okay, first what I did was make a very crude drawing here of the liver, and I'm going to go ahead and take myself off of this and just go straightly to, I thought I was going to take myself off of that. Alright, let's just kind of focus on the screen here. So what this shows, very crude drawing of the liver here. What I want to start with first is heart's hanging out over here, by the way. So you have heart. Hepatic artery is what that represents. Portal vein, hepatic vein. You have your gallbladder hanging out here. Common bile duct is in here. This is where everything kind of ties together. So, first and foremost, let's talk about the role of the portal vein right here. So the portal vein is going to carry nutrients and blood from the GI tract to the liver. All right. GI tract, your intestines are hanging out down here, right? So that comes up into the portal vein. It's an indoor of the liver, so to speak. Liver has some indoors, has some outdoors. If any of those doors get clogged up, then you got problems. So that's the role of the portal vein. You have bile acids that are produced by the liver. It gives about 50% of those bile acids to the gallbladder. We're all familiar, hopefully at this point, that that's what one of the main functions the gallbladder does, is it secretes bile, squeezes it. You can actually measure an ejection fraction on the liver, much like you can the heart. Only 2 organs in the system that act as pumps within the body. So 50% goes there. The other 50% of bile gets excreted into the duodenum. So half of it goes to the gallbladder. The rest of it comes down here, goes to the intestines, And for those of you who enjoy trivial things from the Who Cares department of anatomy and physiology, the rest of that bile that gets excreted into the duodenum, that's what makes your poo look brown. So in case you ever had a burning question about what makes my poo look brown, now you know. So there we go. All right. So that's a breakdown of kind of what happens over here. The liver overall, and then you have the liver is kept alive by the hepatic artery, which gets blood from the heart, goes to the hepatic artery, comes into the liver, and that keeps the liver well perfused. We'll get to some of the other little squirrely things up here in a second. So, for the longest time, at least typically at the bedside, in the role as a bedside nurse, which you all are making the transition from now to that of a provider, we for the longest time thought of liver enzymes as simply just being AST and ALT, right? We'd get morning labs or evening labs. You check your survey 14, and if you wanted to know how your patient's liver functions were doing, first thing your eyeballs would go to would be what? Your ALT and your AST, right? Kind of like you would in creatinine for kidney functions, yeah? So, there are literally about 6 other liver enzymes besides your AST and your ALT. Those are probably the most commonly known, what you most commonly deal with. Many more besides that. We're going to talk about some of those today. But we'll start off with what we know, okay? What we're most familiar with anyway. And that would be your AST, also sometimes referred to as an SGOT, but most of the time you'll see it as AST. So AST has the least amount of specificity of all of the liver enzymes. Okay? Least amount of specificity with the AST. Now, what the AST and ALT are, those are enzymes that are within hepatocytes. Hepatocytes are liver, sites, cells within the liver. Okay? They all hang out here in this bad boy. So, AST and ALT are enzymes within those hepatocytes. When the hepatocyte dies, usually from injury, they will increase, much like cardiac enzymes. When you have injury to the muscle of the heart, right? You've suffered an acute MI, there's damage to the heart wall, where there's ischemia. Those cardiac enzymes elevate, right? So same thing with the liver. They will increase. In liver failure, though, your enzymes, meaning your AST and ALT, many of the time will be stone cold normal. Think about it. Think about a patient that comes in with CHF. Majority of the time, they have stone cold normal cardiac enzymes, right? They aren't going to come in rocking a sky high troponin on you, right? They aren't having an acute injury, all right? To the muscle of the heart, anyway. They have all this fluid around the heart that it doesn't know what to do with, but anyhow. So think of it like that. Then you have your ALT, sometimes referred to also as SGPT. That is more specific, has more specificity. Again, as you can tell, I'm not nearly caffeinated yet this morning, than the AST does. So, the AST, and the reason why, here's an example. With your AST, it will elevate in all forms of liver injury. Okay? All forms, AST is going to go up. However, it is only a reliable indicator for recent injury to the liver. It tells you nothing about residual function, which again is why I just said a lot of times it can be completely normal in the setting of liver failure or chronic liver disease, also referred to lots of times as CLD. So, it gets down here. So I have your AST and ALT. So AST will increase with all forms of liver injury, but it tells you nothing about residual function. ALT, more specific. Consider the L for, I don't know, lots more. That's the mnemonic that I use to try to remember it. So that's a whole lot more specific. It's real technical, right? Anyway, it will decrease when things start to get better with the liver after an injury or insult, or when all of the hepatocytes, all of the cells are dead. So that's why it's a little bit more specific. So some other forms of liver enzymes that we normally don't consider to be a liver enzyme. Let's go up here to the upper right corner. Albumin. All right. Albumin is a protein that's made in the liver. About 65% of our serum protein that floats around in the body, which you also get on a Chem 14, is composed of albumin. All right. Albumin will decrease in the setting of CLD, which I just talked about, chronic liver disease or a chronic liver injury. Main thing to remember, chronic. So albumin decreases with a chronic liver injury. It hangs out for quite a bit of time in the hepatobiliary system. It has a half-life of about 20 days. So that covers albumin. Let's talk about PT. PT-INR. We commonly think of them as coags, right? Measuring clotting factors. Believe it or not, PT-INR is one of the most reliable and one of the most important indicators when talking about liver enzymes. It is actually a liver enzyme. We use it to measure clotting factors, but it's a liver enzyme. Why do we use it to measure clotting factors? Because clotting times require enzymes that are made within the liver. So you have somebody that has abnormal LFTs. A lot of times, whether it's from an acute or chronic liver issue, a lot of times you will see those people rocking an INR usually well above 1. Sometimes as high as 1.8 to 2.2, like someone who's taking Coumadin. They aren't taking any antiplatelet medications. Their liver is just shot. It can't clot, so you get these sky-high PT and INRs. Anyway, the key thing with your PT and INR, it is reliable in the setting of both acute and chronic liver issues, injury or disease. Okay? Typically, hopefully you guys know this by now, there's a 10-to-1 ratio. Is what you typically get with the PT to INR. So your PT to INR ratio is a 10-to-1. So if you have a PT of 10, your INR is going to be 1. Simple math, right? Even in my non-caffeinated state right now, I have the feeble brain power to put that together. So it is also the very first indicator that things are going bad with the liver, when the liver is failing, whether from an acute injury or something chronic that's been cooking for a long period of time, starts to make the liver say, no mas, I'm checking out. So, you have all kinds of clotting factors that are involved there. Vitamin K. Also, if you go down your coagulation cascade, I think it involves let's see, factor 2, factor 7, factor 9, factor 10. Most common factor we hear of in clotting disorders is what? Factor 5, Leiden. It plays a small role in that. It also plays a small role in 1. But anyway, so. And as we all know, Coumadin can greatly skew your PT and INR. So can hemophilias. Hemophiliacs have messed up PT INRs. Kind of throw you for a loop. So anyway, that's what we have. That's what we have for that. So hopefully now some of this makes a little bit more sense. Somewhat. I don't know. Maybe I confused you a little bit. We'll see. All right. A few other things to talk about here while we are on this page. So out here I have RBCs hanging out. Red blood cells, right? Put a little X through them. Reason being is, so red blood cells are circulating out there. They have a lifespan of approximately every about 120 days. So that means every 120 days a red blood cell dies. When a red blood cell dies, we have a name for that. What do we call that? Call that hemolysis, right? Heme, meaning blood, and olysis, the destruction of a cell, right? So every 120 days, red blood cell is done for, gone, all right? It dies. It goes through hemolysis. So as it breaks up, it then releases a boatload of what I put here, UNCB, unconjugated bilirubin, often referred to as indirect bilirubin if you look at labs. So you have unconjugated bilirubin, indirect bilirubin. You also have conjugated bilirubin, which is also known as direct bilirubin. So what happens, red blood cell lyses, it dies, it releases all of this unconjugated bilirubin, goes straight to the liver, where enzymes or hepatocytes then turn this into conjugated or direct bilirubin. Okay? So then it looks for an escape route after it's gone through this metamorphosis. And it likes to come out either right here. You have the left and right hepatic duct. That's what these are right here. So when these hepatic ducts are closed for business, when they fail, that causes bilirubin to build up in the blood. It has nowhere to go. It can't escape out here. Its escape route is shut off. Hepatic ducts are closed. So what will happen at that point is the direct or conjugated bilirubin has a little bit of a brain. It's a little smart. It says, okay, these doors are closed. I'm finding another route out of here. What can I do? Well, conjugated bilirubin is water soluble. So, as we know about molecules that are water soluble, they can pass through where? They can pass through the kidneys, right? So these bad boys find an escape route out of the liver, and they piggyback through the blood to the kidneys, where they are then excreted out through urine, and that's what we look for in a Reuben. In a UA, when you see bilirubin, a buildup of bilirubin in the urine. It's because of that. All right. Whenever someone comes in and they give a urine sample, and it looks like they just peed a root beer float. Okay, they have hyperbilirubinemia, something like that. I messed that up again. I'm still trying to get caffeinated. It's still 5, not even 6 o'clock in the morning. So you see that a lot of times in the cases of rhabdomyolysis. A few others. Liver failure. It's one of the things where you can tell where there's a problem with the liver. If someone is talking about every time they pee, it has this dark brown color to it. Looks like they're peeing iced tea, Coca-Cola, root beer float. Those are some of the terms you may hear. Then it's not necessarily there's an issue with the kidneys. You need to be thinking more, something may be going on with the liver that's causing this to form up to be excreted into the kidneys. So keep that in mind. All right, another liver enzyme. I didn't write this down here. I apologize. You'll have to listen. Alk-Phos. You'll see that on the survey 14, right? Alkaline phosphatase, Alk-Phos. 3 areas where you see Alk-Phos, or where it's produced. You will see Alk-Phos can come from the liver. Also, if you have cholestasis, gallbladder, you'll see an elevation in Alk-Phos. So Alk-Phos primarily comes from the liver. 2 other places you can see if your Alk-Phos is elevated, 2 other things that produce Alk-Phos. You can see that in pregnancy. Pregnant women. What do they have outside of having a baby on board? What's between them and the baby? Placenta. Placenta produces a boatload of Alk-Phos. So if you ever draw survey 14 on a pregnant woman, your Alk-Phos will be elevated. It's because they have a placenta. You also will see Alk-Phos is almost always elevated in kids. It's because kids are doing something that we stopped doing a long time ago. In some cases, some of our cases, some of us a lot longer than others. Kids are still growing. We are not. You will see Alk-Phos produced by bones. So you can also see it in the setting of trauma. You know, someone wheels in and they have an open tib-fib fracture. When you're doing your trauma panel, you check a survey 14 on them. Your Alk-Phos will be sky high. But anyway, this is not acute care nurse practitioner. I digress. So those are the 3 areas that produce Alk-Phos. So hopefully you don't ever get a pregnant kid that comes to see you, because Alk-Phos is going to really be sky high. You're going to have a tough time trying to figure out, where is this coming from? Is there something going on with the liver, or is it just because we got a baby on board and we're still growing? Hopefully that's not the case. But anyway, so we do have a blood test that we can do that lets us verify, is our elevated Alk-Phos coming from the liver or coming from someplace else? This is another liver enzyme, by the way. See, there's lots of them outside of what we used to think there were just literally 20 minutes ago. GGT. All right. So your GGT, if you have an elevated Alk-Phos, and you check a GGT, if the GGT is elevated, that means that it is coming from the liver. End of story. Slam dunk. Open shut case. Pretty simple. If your GGT is normal, then it's coming from bone, or, like I said, you have a pregnant patient on your hands. So, GGT is what we check to confirm our suspicion that our alk phos is elevated because it's coming from the liver. And then I've already mentioned briefly here your unconjugated bilirubin, right? Or your indirect bilirubin, and then your conjugated bilirubin, your direct bilirubin, right? So the difference between, you'll always have a total bilirubin typically on your survey 14. You'll see total bilirubin. So when you're doing a workup in a patient with abnormal LFTs, great, you have that on your 14. On your 14 you'll have your AST, your ALT, you'll have an albumin, and you'll have a total bilirubin, right? So we already talked about we also need to get PT and INR, and your alk phos will be on that 14 as well. We need to get a PT and INR. We need to get a GGT, that alk phos is elevated, to make sure it is coming from a hepatic source. And then you also want to get a direct and indirect bilirubin. If you take your total bilirubin and subtract the direct bilirubin from it, you get the difference between the two is your indirect bilirubin. So, a normal total bilirubin is typically between 0.1 to 1 milligrams per deciliter. Whenever that gets above a 3, your patient should have some overt form of jaundice, whether that be them walking around looking like a Chiquita banana or simply some scleral icterus. Whenever that total bili gets above 3, there should be some very overt signs of jaundice. So, an elevation in direct bilirubin, conjugated bilirubin, always equals damage to the liver. Again, that's why when you see it excreted in urine and someone's peeing iced tea or Coke or root beer float, you need to be thinking liver, not kidneys, because it indicates damage to the liver. That can be from a variety of things. It can be due to drugs, acetaminophen overdose, a pancreatic tumor, stone in the common bile ducts. All right. That'll cause everything to get backed up. It'll close off these hepatic ducts. Blockage of some sort that causes the ducts to be closed for business. You'll see a spike in direct bilirubin. And like I said, it is typically, direct bilirubin typically makes up 50% or more of your total bilirubin, which again is why you see bilirubin in the urine. So, hope that makes sense. Yes? Clear as mud? Alright. Only other thing to mention on, sometimes you see this on boards. I think I got a question about this on boards. Which I thought was silly, but anyway. There's a condition called Gilbert's disease. It's Gilbert's, Gilbert', but some French guy invented it. So it's sophisticated. It's Gilbert's disease. Anyway, it affects only about 5% of the population. And that is when you have a huge surge in total bilirubin. And it's a result of a problem with the enzymes, hepatocytes within the liver that change bilirubin from unconjugated to conjugated, or indirect to direct. Okay? So just in case you come across that down the road on boards, on a Barclay review or something like that, you'll know what Gilbert's disease is. And you can sound sophisticated to all your friends now when you talk about it. I don't know. In Texas we call it some Gilbert's disease. Alright then. Let's move right along. Let's talk about some areas where we see big jumps in your ALT and AST and what it represents. So we'll start with some of the acute issues. Again, this is acute, not chronic. Acute. Acute hepatitis A. You see massive elevations in your ALT. You'll also see elevations in your AST as well, but your ALT is typically going to be a lot higher than your AST. So, history for Hep C, typically something that's been ingested through an oral route. How do we diagnose it? If you ever order a hepatitis panel, you'll get all this stuff coming back, these IgMs, all sorts of different ones, but we're looking for IgM. M, by the way, when you're doing IgG and IgM, here's a little mnemonic for you. IgG means that it is gone. The G, the last G anyway, stands for gone. IgM, I always remember the M as being miserable, meaning that this disease, whatever it may be, is still active, therefore the patient is miserable. So you draw a hepatitis panel, you're looking, if you suspect acute hepatitis A, they should have IgM, so the IgM for miserable, still active disease, anti-hepatitis A virus. Alright, Hep B, very similar to Hep A, acute Hep B I should say. Big spikes in your ALT, you'll have some spike in your AST. History, usually transmitted through body fluid. You will have positive IgMs because the patient is still miserable, actively has the disease. And your core and surface hepatitis B antibodies will be positive. So, that's acute Hep B. Acute hepatitis C. Massive spike in ALT as compared to AST. Sometimes AST really doesn't even move that much. It can be normal, or maybe no more than 1.5 times the upper limits of normal. Huge spike in your ALT. History, typically IV drug abuse and sex. You can also have some alcohol-induced, but usually it's IVDA and sex. So what are we looking at? You're going to see your anti-hepatitis C virus antibodies be positive, or hepatitis C virus RNA, that's measuring viral loads, will be sky high. So that's in the setting of acute hepatitis C. These people are pretty stinking miserable. Just imagine, huge insult to the liver, Huge, right? Look at that elevation right there. Sky high. These people feel like junk. They are dragging butt. They'll be complaining of fatigue. They may or may not walk in looking like a Chiquita banana. You may find icterus, overt icterus somewhere during your physical examination, but they will feel like absolute junk. They may be complaining of fatigue. They may be complaining of these just diffuse myalgias and arthralgias, meaning hey, I don't feel good and I hurt all over and I can't figure out why. Feel like I just started a CrossFit workout and was flipping tractor tires, and I haven't got up off the couch and exercised in 15 years. Okay? They feel awful. They feel awful. So explore your history. And there we go. This also leads me to that whenever you have someone that comes in with abnormal LFTs, in addition to the markers that we talked about previously, you want to draw a hepatitis panel on these patients to find out if there's an underlying acute or chronic form of hepatitis going on, which we'll get to in a minute with the chronic stuff. So, anyway. So this leads us to our people who like their drinky drink. Our alcoholics. They're such fun people. They really are. They can be rather entertaining in the clinic. So the funny thing is, I compare alcoholics to COPDers. COPDers typically are well compensated in their disease, right? It's not uncommon to have someone who's had COPD for years, most of which are still smoking. Gotta love that. At least I know the tobacco companies do. But anyway, so you have your 40-year smoker who comes into the clinic, smells like a dirty ashtray as I walk down the hall, and have their 4-pack a day Marlboro habit. And you walk in the room and they're smiling at you. Hey, how's it going? Blah, 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 blah. They're talking at you and smiling and happy-go-lucky. And you stick a pulse ox on them and you get a SpO2 of like 85 or 86%, which a lot of you freak out over. Happens in clinicals all the time. So, because you get excited about the number. Oh gosh, sat in 85%. I got to do something. You really don't. Again, these people have been walking around like that for years. They've compensated to that point. That's where they hang out. They hang out in the mid-80s. No big deal. You look at the patient, and like I said, you walk in the room, they're smiling, they're talking to you, they're carrying on. They are in no sign of respiratory distress. Yet you go freaking out over this oxygen level of 85% and start throwing oxygen on them, and you're wanting to order nebs and, all kinds of crazy business. Don't. They've compensated. That's where they hang out at. So your alcoholics, their liver has basically kind of gotten used to them kicking back a 6-pack of beer a day and a 5th of whiskey and chasing it with a pint of vodka. So they will have very small rise, if any, in their ALT and AST. This is even in an acute setting. Chronic, you can see it's the same thing. History, have you been drinking? Diagnosis based off the history. So an ischemic event to the liver, acute ischemic event. Liver is dying. You've had an injury to the liver caused by trauma or caused by kicking back a bottle of Tylenol all at once. It's most commonly where you'll see this. Massive, massive spikes in both ALT and AST. So these are people who decided that they're checking out and they're emptying their medicine cabinet down the back of their throat, and they have 2 bottles of Tylenol at home. Or they went to Sam's and they got one of them big old huge tubs of Tylenol that you could, after the bottle's empty, you could fill up and use it as a swimming pool type kind of thing. So huge spikes in ALT and AST, both sky high. These people are barely alive, so you're looking at a blood pressure like 50/30. That's being generous, probably. So that's your acetaminophen toxicity patient. All right. Didn't mean to turn that blue. Don't know why I did that. Don't know why it won't let me get the very bottom one down here. It's cutting off. There's a couple underneath there. Anyway, let's talk about chronic stuff. NASH, non-alcoholic steatohepatitis. That is what happens when we go. There's a PowerPoint lecture up there that talks about fatty liver disease, NAFLD, non-alcoholic fatty liver disease. Very common. NASH is a progression from that, if you've looked at that PowerPoint already. Hopefully you have. So again, you see mild, with all the chronic liver issues, you see these very mild elevations in both the ALT and AST. They aren't sky high like they are up here with an acute issue, right? So NASH, we'll kind of, for this time being, make NASH and NAFLD interchangeable because they're both chronic. Non-alcoholic fatty liver disease and then non-alcoholic steatohepatitis, the progression of fatty liver disease. So, fatty liver disease. You may see a little bump in your ALT. AST will probably stay pretty close to normal. Or you may see stone cold normal LFTs. Probably one of the most common reasons for an elevation or abnormal LFTs. You see a little bump in LFTs when you get your survey. And the reason it's so common is because you see that in the setting of obesity and metabolic syndrome. Metabolic syndrome, that's our holy trifecta of what? Hyperglycemia, hyperlipidemia, hypertension. While it can affect skinny people just like it can obese people, you typically find this in people that are obese. They have fatty liver disease. About 30-something% of the population walks around with fatty liver disease and they don't have metabolic syndrome. This increases significantly in our diabetic population, those that have the holy trifecta of metabolic syndrome. Upwards of almost, I believe, 70% will have a fatty liver disease. It's also a very common thing that you will see when you order ultrasound, abdominal ultrasound on somebody. Say you think it's their gallbladder, you think they have acute cholecystitis, so you order an abdominal ultrasound. And a lot of times there will be an incidental finding. They may very well, it may confirm because you've done such a thorough physical assessment. You've done a outstanding abdominal exam. Hopefully, you've been taught that anyway. They have a positive Murphy sign. So you order the ultrasound to confirm your diagnosis and your suspicion that they have acute cholecystitis. And sure enough, on the ultrasound, it says acute cholecystitis. And then underneath that, number 2, it may also say diffuse fatty infiltration of the liver, or fatty liver disease, or something to that effect. It'll be one of those two. And that's just oh, by the way, look what we found. This patient has a fatty liver. So, very common. All right, chronic alcohol use. Just like acute alcohol use, basically. Go figure. Apparently the liver liked it some drinky drink. You do have episodes in forms of autoimmune hepatitis. Typically affects young women. You can diagnose that by ordering an autoimmune panel, which you should also do, by the way, on anybody that has elevated LFTs, abnormal LFTs. In addition to the enzymes and markers that we talked about, Hepatitis panel, autoimmune panel. Reason being is there can be an underlying autoimmune hepatitis, especially if it's a young female. Not exclusive to females, but you typically see it in females. Hemochromatosis. Had a patient with this yesterday that one of your cohorts got to see. So this typically affects men. Again, not exclusive to men. It was a male patient that we had yesterday, 58-year-old male. But typically is found in men. LFTs, not that impressive. Ferritin sky high. So that leads me to the other thing that needs to be drawn when you have abnormal LFTs. In addition to the markers and other enzymes that we did not think had anything to do with the liver that we now know better, we also need to do what? Hepatitis panel. What else? Autoimmune panel. And the third, iron panel. You will see anemias, and especially that deal with disorders of iron, go hand in hand with the liver. That's why we put this stuff together, comboed it together. So you'll typically see a ferritin greater than 1,000. Another word for hemochromatosis, it's commonly referred to as bronze diabetes. You typically will see it in diabetics, number one, and they have this bronzed appearance, this bronzed glow to them. Take someone, imagine someone who has been vacationing down in the Caribbean for the last 3 weeks, and you know that there is no way possible this patient has done so. Could you ask, well, let me see your pictures from your vacation down to the Bahamas. I've never been. Let me see. What are you talking about? I've never been down there. Really? Because you have this beautiful looking tan and all this stuff. It's not that. It's from a buildup of this ferritin sky high. So you have a buildup of iron in the endocrine organs. Pituitary, pancreas, thyroid, kidneys, all the ones that play a function in the endocrine system. Liver enzymes may be pretty close to normal, but you're going to get this sky-high ferritin. These people go to a hematologist, they get phlebotomized. They actually get the ferritin pulled out of their blood. Because a buildup of that ferritin can be bad news long term. Patient I had yesterday had a ferritin of 2,801 or 2,810. It's 2,800. It was impressive. All right. Wilson's disease. This is probably the only thing in the chronic setting where you get a fairly decent spike in both your ALT and AST. You will typically see this in young patients. Not just adolescents, but young adults. It's characterized by chorea-like movements. It'll present sometimes as a neurological or neuromuscular disorder by chorea-like movements. Think Huntington's chorea. If you don't know that, just think somebody who is shaking all the time. Their head, they they look almost like they have Parkinson's. Essential tremors in the extremities, and their head and neck is moving all over the place. All right. They will have low ceruloplasmin, which basically means it's sucking up copper, and they have a very low alk phos. Anyway, that's Wilson's. All right, so there's acute and chronic, what they look like in terms of what the ALT and AST should be doing, and some characteristics of those. I don't want to do that. All right. So, let's talk about some other portions of the hepatobiliary system, and then we'll be close to being done. Hopefully it's been helpful for you so far. It should apply to your CDM that you're doing. So, primary biliary cirrhosis. So we're dealing with cirrhosis, we're dealing with what? We're dealing with liver failure, right? Usually chronic in nature. Patient has ascites, they have a positive fluid wave. Alk Phos is going to be sky high. You're going to see elevation of total bilirubin. Says women can affect men, more in women. Pruritus, they are itching all over. These people are jaundiced, they have ascites. You'll walk in the room, you'll see them scratching like they just walked through some poison ivy or something. They itch all over. Not enough antihistamines in the world to keep these folks from itching. Alright? And like I said, there's overt jaundice. Typically at this point when you're dealing with cirrhosis, see it in the skin. Not always, but you should at least have a bunch of scleral icterus that you're able to identify. So anyway, everything's just dying here. The intrahepatic ducts are dying. They're being destroyed by an increase in what are called portal granulomas. They kill those intrahepatic ducts. Lipids panel looks awful. Looks like they've been shoving pure sticks of butter down the back of their throat. Anyway, that's primary biliary cirrhosis. Primary sclerosing cholangitis, similar in presentation with Alk Phos and total bilirubin. It's typically going to be caused in people that have ulcerative colitis. Not necessarily Crohn's. Sometimes in Crohn's, predominantly UC, ulcerative colitis. And again, just like above, it affects the intra and hepatic ducts. In this case, they are getting clogged up due to fibrosis. A bunch of tissue, right? Clogging up the ducts in this case. They aren't being destroyed. There's just all this fibrotic tissue. Hence the word sclerosing. It's no different when we think of atherosclerosis when we're talking about coronary artery disease. Coronary arteries in your vessels. So, gallbladder. You get an obstruction in the large bile duct, typically. That can be caused from a buildup of sludge in the gallbladder. That can be caused by a single stone, would be a boulder in that case, or a bunch of gallstones. So, Alk Phos goes up, total bili goes up, these people are miserable, pain, right upper quadrant pain, positive what sign? Murphy sign, fever. What else have we talked about with gallbladder? Nausea, with or without vomiting possibly, pain that radiates directly behind the gallbladder, going straight through to the right lower portion of the back. And where else do you get referred pain with gallbladder? Your right shoulder. Correct. So what do? Abdominal ultrasound. And then if they do have a huge obstruction, they're going to get an MRCP. There we go. That leads me to the final thing that you need to do in the workup of a patient with abnormal LFTs. Everybody gets some jelly on the belly. They need to get an abdominal sono. Not just a sono of the gallbladder, not just a sono of the liver. You want a full abdominal ultrasound because you want to take a look at the entire hepatobiliary system. Right? So, to recap, abnormal LFTs. We no longer know that LFTs are just AST and ALT, right? We've now figured out that there are a lot of others that are considered enzymes. Some very important, some that give you more information than just what your ALT and AST will do, right? So you have your survey, you have elevated or abnormal ALT or ASTs. Look at the degree of elevation. That should clue you in as to if something is acute or chronic. Look at what is high, AST or ALT. You then work it up exactly the same. Even if there's just a mild elevation, work up still the same. If it's something chronic, or if it's something fairly benign like fatty liver disease, the workup is still exactly the same, unless you get that ischemic patient that's taken 2 bottles of Tylenol and they're in the process of dying before your very eyes. But again, that's really more, that's not going to come into a family practice clinic setting. So I take that back. It shouldn't come into a family practice clinic setting. I've had it come in before. Immediately got shipped to the emergency room, but anyway. So, you have your chemistry, 14. So you have some of your liver enzymes already on there, right? You have your AST and ALT, which we used to think that was it. End of story. That told us everything we need to know about the liver. Not so fast. Check that alk phos. It's on that survey. And you have your albumin, which should be on the survey. And you have a total bilirubin. So you have some of the pieces of the puzzle. So you need to check GGT, especially if that alk phos is elevated, because that tells us, confirms for us that it's coming from the liver. You can see I'm more caffeinated now. I'm shaking my chair back and forth. I've got some caffeine flowing through me. All right. So you check that, right? That's high. It's coming from the liver. If GGT is normal, you have an elevated alk phos, it's coming someplace else. You have a pregnant patient on your hands or something going on with bone. You check PT and INR, where we used to think were coags. As we mentioned earlier slides, some of the most important liver enzymes, because it's very reliable for acute and chronic issues. Tells you what's going on. So check your PT INR, right? We also then need to, you already have your total bilirubin. We want to see what our direct and indirect bilirubin's doing. Conjugated, unconjugated. So make sure you order those as well. Also talked about ordering hepatitis panel. Saw on the acute slide or paper drawing that I did. Again, I apologize for the god-awful scribble. You could have acute hepatitis going on. You could have chronic hepatitis going on. My screen cut off a couple things at the bottom. Hep C was at the bottom because we do have chronic hepatitis C. A lot of times the AST and ALT are barely elevated or pretty close to normal. Anyway, so you want to check hepatitis panel. You want to check an autoimmune panel, because that shows you can have autoimmune hepatitis that can be driving the liver enzymes to be abnormal, especially in young women. You also want to check an iron panel, right? Shows you like in the hemochromatosis, ferritin goes sky high. Also, you'll see a lot of anemia, specifically iron deficiency anemia goes hand in hand when you have acute or chronic liver disease or injury. And put some jelly on the belly and get your abdominal ultrasound. All of that you can do as a family nurse practitioner in your clinic. You don't have an ultrasound machine in your clinic, you can certainly find some place to send them out to. All that needs to be done before you refer to GI, right? If you just have someone that comes in with just a slight elevation in their ALT and their AST and you send them off to a GI or a hepatologist, you will get a very nasty phone call from said GI or hepatologist, and they won't accept any more of your patients because they don't think you know what the heck you're doing. Because you did not do a complete workup. And then what they have to do when that patient shows up on the doorstep is say, here's your lab slips to go get all these labs done, go get your ultrasound, then come back and see me. Because they don't have all the information at that point, right? So, the other thing that you need to do when you get someone that comes in with abnormal LFTs, here, let me open up my slide here. Let's do this. My PowerPoint. Hopefully you've looked at this. We've already been through this. All right, what are LFTs? All the stuff that I've added on there we just talked about. There's some more stuff in there that I've talked about this. This is what chronic liver disease looks like. Some other stuff that you'll see, ascites, hepatomegaly, what caput medusae look like. You'll get muscle wasting. Here's what that looks like. There's some nice scleral icterus right there for you. Measuring liver span, right? Hepatomegaly. So, pulmonary erythema. Like I said, NAFLD, non-alcoholic fatty liver disease. And so, like I said, that says 20%. It's more like about 30% of the population walks around. They have fatty liver disease. Goes up in metabolic syndrome. Here we go. So your patients that are obese, BMI greater than 30. 70% of obese patients have fatty liver disease. So here we go. That's approximately 45% of the U.S. population. This is dated now too. That's back from AGA in 2012. They put out a position paper just this year where some of that's been updated, but you guys won't be responsible for knowing that because the boards typically lag a year behind. So that's why I kept this with the old guidelines. They tend to update about every 4 years. And like I said, I was off by one. I said 70% and 69% of diabetics have fatty liver disease. Anyway, number one cause for elevation in ALT, fatty liver disease. Anyhow, then we progress on to NASH. That can then lead to cirrhosis. That can then lead to the death by liver. Not my idea of a good time. Anyway, risk factors, again, primarily obesity, metabolic syndrome. All right, let's see here. This just talks about managing NASH and fatty liver disease. The only thing that works is weight loss. There's all this other stuff you may read about, but anyway, it is not proven to do anything. Let's talk about statins real quick. So your people that have fatty liver disease, non-alcoholic steatohepatitis, even some chronic conditions, they typically will die of cardiovascular disease or complications before they die, before their liver completely checks out on them and they die. It'll be some cardiovascular that gets them. So we give statins in people that have just fatty liver disease and NASH. All right. However, we establish that, as we talked about, by putting jelly on the belly and figuring out that you get fatty liver disease. So if somebody comes in and they're on a statin and they have elevated LFTs, you don't know what's causing those LFTs to be elevated. You don't know if it's hepatitis. You don't know if there's an obstruction somewhere in one of the hepatic ducts or common bile ducts there. You have acute cholecystitis. Could also very well be medication induced from the statin. So, first initial evaluation, elevated abnormal LFTs. You need to stop all hepatotoxic medications. Hepatotoxic, toxic to the liver, right? Statins can be, particularly in higher doses. You need to identify and stop all hepatotoxic medications. Bring that patient back in about 6 weeks, recheck the liver enzymes, see if they're still elevated or not. Could be medication induced. All right. Let's talk about Tylenol overdose, toxic liver stuff. This goes over hepatitis, which we just kind of went over. I kind of drew all that stuff out for you. This talks about in terms of the use of NSAIDs and Tylenol in the setting of chronic liver disease. Anyway, so look at these slides. Talked about this a little bit already. Chronic liver disease. Some of the symptoms you'll see. And again, you can't have chronic Hep C and Hep B on my scratchy scratch handout business. It didn't show up on there. Cut off on the bottom of my screen for some reason. So, signs of cirrhosis, advanced end-stage liver disease, what you're going to see. There's when to refer to GI. Here's the key thing here. Known implicating agent has been withdrawn and liver function continues to worsen. So that initial patient presents, you've identified, you've stopped all the hepatotoxic medications. If they're on a statin, you've taken them off that. If they were kicking back high doses of Tylenol, you've stopped that, or any products that contain Tylenol or acetaminophen. There are antidepressants that are considered hepatotoxic. There's lots of stuff that's considered hepatotoxic. Remember that first pass effect. A lot of stuff goes to the liver, right? So if you've withdrawn that known agent, you bring them back in 6 weeks, you recheck their LFTs, and they are still rocking some sky-high numbers, or their liver functions worsen, go to GI. But also make sure that you do all this before you send them. Hepatitis, autoimmune stuff. All right, really you can just do an ANA. Don't do a full autoimmune panel. You can get by with just an ANA. And if you're going to stick a needle in it, might as well just do it. Iron studies, we talked about that. Jelly on the belly, sauna. In addition to the fact that you've already checked your indirect and direct bilirubin, your GGT, your PT-INR, so on and so forth, right? Okay, so I hope that was helpful, a little bit long, but I thought that might clarify a few things that you've read here recently. And I know you're working on your CDM right now, which I think is due coming up on Sunday, on the 9th. So I have outlined everything that you need in that CDM, how you should approach that CDM from the GI standpoint anyway. There's some anemia issues in this CDM that you have to address as well. I found also last night, for some reason I couldn't sleep. I was focusing on you guys last night for some reason. When I don't sleep, I focus on you guys. So I know you guys probably aren't sleeping a lot right now either. And I found a anemia, quick anemia 101, a nice little, I think it was like 3 or 4 pages long, a little quick reference guide for anemias that I used when I came out of school for about the first 6 months of practice to kind of make my life easy until I had all of it down pat here and could rattle it off like that. So I'll try to post that later on this evening for you guys, if I'm still awake later on this evening. I imagine I'll be drinking a lot of coffee today. So please, I know this was long, but a lot of information in there that should hopefully make your life a lot easier as you're doing this CDM. Make sure you cover all of the bases, order all of the things that we have talked about. Make sure you tell me why you are ordering this. You can't just say, because Dr. Wettendorf said so in his video. I am not a guideline or a peer-reviewed journal article. I am not a reference source. So, believe it or not, people in past classes have put Dr. Wettendorf, 2015 as their rationale. That just killed me. But anyway. So look at the stuff that we covered just now for your CDM. For your test, your midterm, look at that one slide that I just put up that says FMP1 LFTs. That talks about fatty liver disease, NASH, and so on and so forth. Because like I said, fatty liver disease is very, very common. You will see that in practice. You will see that on boards. You will see that on your midterm exam. So if you want to know what to look at for your midterm exam, you got it. That FNP1 LFT slides that we just blew through quickly, look at those. Look at the stuff that I drew for you. You'll see that on your midterm, I bet. All right? And then make sure when you're documenting your rationale and your guidelines, as you saw through my PowerPoints on there, all of my guidelines came from the AGA, American Gastroenterological Association. AGA guidelines. I think there is, within your module, there is a AGA position paper or guideline paper on fatty liver disease and LFTs in general. So that's your source. You can find it in UpToDate or go to the AGA website and you will be able to find the guidelines for abnormal LFTs. So, hope that helps. Again, I thought, as yesterday in clinicals, had several patients with abnormal LFTs that one student got exposure to, and I just thought it would be fair that the rest of you guys had the same experience, because we got to talk about that a lot yesterday. Student got to witness it firsthand, and I think everyone should have a level playing field here when working on your CDM. So, if you've already completed your CDM, maybe you use these next 5 days to go back and look at some of this stuff and see if all that was included in your CDM and in your workup. If so, a gold star for you. So, I'm going to go keep chugging coffee. I'm going to see if I can't find possibly a way to stick an IV in me and just put it in centrally throughout the rest of the day, since I got about 2 hours of sleep last night. Just kind of infuse some caffeine all day long. But anyway, hope you guys have good days. Any questions about this material, please feel free to call me, text me, shoot me an email. But hopefully you find this helpful as you are putting together your CDM for this weekend.